looks like it's about time. So thank you all so much for being here, for arriving on time. I appreciate that very, very much. My name, as I said, is Jay Ziebart with Plant-Based for Life. And Dr. Megan Mitchell Cox and I started the Disease Prevention and Reversal Virtual Summit. And that's how we got started doing this. And so now what we've done, we had such a great turnout and such a great response to our summit that we really want to continue to provide as many services as we possibly can. So we have started this monthly webinar series. So it's the first Wednesday of every month. It's basically like a lunch and learn. So noon to 1. And going first will be Dr. Megan Mitchell Cox, and her topic for today is the bare bones of bone health. If you have not heard Dr. Megan Mitchell Cox speak, you are in for a treat. She's absolutely fantastic. And I'm going to go ahead and let her introduce herself. But again, well, hi, Wade. So good to see you. So if you have any questions or comments, remember Q&A or chat buttons, and we will get to as many as we possibly can. There she is. Welcome with me, Dr. Megan Mitchell Cox.
Okay, thank you so much, Jay. If you could please give me the ball and I can start sharing my screen here.
Absolutely.
So great to see you all. So we'll start the presentation in just a minute. For those of you, if we haven't met before, I'm board certified in internal medicine, so general practice medicine for adults, but also in lifestyle medicine and actually most recently obesity medicine as well. So today we'll talk about joint pain, arthritis, and also bone health in general. Usually we talk about the thinning of bones, osteopenia and osteoporosis. What do those mean? What do we look for? And what most people's question is how do we address it? Okay, so the bare bones of bone health. So first we'll talk about arthritis. Very honestly, that's going to be a shorter segment. And I did that because in going over it, a lot of it's more individualized. So we'll go over that piece, but then really the bulk of it today will be osteoporosis. So for those interested, please let us know if you want a webinar specific for joint pain and arthritis, because today will be a little bit more overview on that subject so we can really dive deep on osteoporosis. So to start, I like to ask questions to get us all thinking. So at what age do we have the highest number of bones? More like factoid, fun ones. So at what age do we have the highest number of bones or the most bones in our body? At what age are the bones the most dense? Do men need to be concerned about osteoporosis? And frequently I get this in the office, my hip's been hurting. Can this be osteoporosis? So to start with that, so babies have the most bones. We're born with more bones, and the number of bones end up fusing as we age. So 270 bones as babies, and we end up having 206 as adults. Bones are the most dense about 21 years old. So really the most bone growth happens between 10 and 20 years old. Before that too, but as far as the density. And then we really hit our peak. So when people say it's all downhill from here at 21, not that I've ever heard that, but as far as your bones go, it is accurate. And about 30% of fractures are in males. So a lot of times we talk about it's really usually the postmenopausal white female in particular, although Hispanic females and Asian females are also more at risk for fractures than are Black females. Because they have more bone density. So men, though, they kind of get left behind, but a good 30% of the fractures are in men, so definitely not something we should be overlooking. And osteoporosis is painless, so no symptoms at all. So first off, we'll go through arthritis. So this is a knee joint. So this is what our joint normally looks like.
I'm sorry, Dr. Cox. Would you be able to speak up just a little bit, please? We're having a little trouble hearing you. Thanks.
Okay, thanks. Can you hear me? Okay. Maybe I'm sitting too far back. Thanks. So this is what our joint normally looks like. So this is a knee joint, and this is a healthy knee joint. So we see the femur up here, and then down here is our lower bone. So any two joints. But then inside the joint, you have this capsule, and you have fluid in here with cartilage on either bone side. So this makes the joint nice and smooth when it's moving. There are a number of different types of joints, but this is very similar pictorial of what it looks like in our joint. Just to check in, can you all hear me?
That is better. Thank you.
Okay, thanks. So first off, we'll go through the causes of arthritis. I said osteoarthritis, but really arthritis in general. So age is a big cause. As we age, there's more of a risk of arthritis. Overweight and obesity, which we could go over the numbers, but they're quite staggering. And I'm sure you all have heard them on the news and elsewhere that we're really, as a country, really, as a society, humans in general, the whole world, but any Western civilization, we're really going to be battling obesity for decades here. Chronic inflammation, family history of arthritis, and then secondary causes. So that's an inflammatory arthritis and different trauma. So if you've had trauma earlier in life to a certain joint, you have much more risk of having arthritis in that joint. Gout falls in here, and then other arthritis syndromes like rheumatoid, lupus. And again, we won't be getting into those specifically today because it's quite a big conversation in itself. So here we go. When we're looking at a healthy joint, right next to it, we'll look at a joint with osteoarthritis. This is the most common cause of arthritis. So when most people say, oh, I have arthritis, we're talking about osteoarthritis. Usually we just leave out the osteo part because it's so common. And then rheumatoid arthritis over here. So osteoarthritis, again, the most common cause, what you can see in this picture is this bony growth here. So you can see the joint space is gone, and the bone responds by making more bone as a protective mechanism. And then we have additional bone fragments that are growing on both sides, along with this bone-on-bone joint structure, which causes a lot of pain. If we break down the word osteoarthritis, whenever in medicine, whenever we put itis on the end of something, it means inflammation. I call that out because osteoarthritis is an inflammatory syndrome as it comes about. We don't typically think of that. We think of it more as an overuse or a lot of wear and tear on joints, but by definition, it is inflammation. After it goes on for a long time, then we call it osteoarthrosis. I call that out because if you all see any radiology report of yours, you might see it say osteoarthrosis. At that point, the joint changes have happened, but they don't see the acute inflammation in there any longer. So the question is, what can we do about that? So the first, of course, is weight. So with weight, at any weight, we can have arthritis. It's just much more of a risk as the weight goes higher. And the really cool thing is if someone has a lot of weight to lose and they have a lot of pain from arthritis, it doesn't mean we have to drop 50, 100 pounds sometimes. Even a weight loss of 5 to 10% makes a big difference to decrease someone's pain that comes with arthritis. And this, one of my favorite slides, if you all have seen me speak, I'm sure you've seen this slide, because this is what we do, right? 80% of any treatment is lifestyle, and arthritis is right along there. So 80% is lifestyle, so that's what we eat, how we move our body, how we rest our body, how much stress we have. And then on the top 20% is the medications and supplements and surgery. So these top two portions, this is where the medical community comes in typically. So I want to talk about the lifestyle piece of it. Again, we'll go through quickly here, but because that's what makes the biggest difference for people. So this is a food pyramid. It's Dr. Fuhrman's food pyramid, excuse me, but there are multiple of them. They all look very similar. But when we're talking about if we're using food as medicine, we're talking about we want a diet that's really high in nutrients, vitamin, minerals, antioxidants. All of these foods on the bottom of the pyramid here, these all have that criteria, but even more importantly for joint health is that they're anti-inflammatory. So the inflammation that causes damage or pain to joints, because sometimes inflammation can cause a lot of pain without showing any damage to the joint. The foods on the bottom of this pyramid reduce the amount of inflammation in a person's body, so they're not feeling as much pain or they're not doing as much damage. The foods at the top of this pyramid, to have sparingly or not at all, are ones that cause inflammation and cause more pain. Nightshades. Just to nod our head to nightshades here, because we get this question a lot, right? So people avoid nightshades because they've heard that it can worsen joint pain or worsen arthritis. So back and forth with it in the literature, but it has been shown clearly that nightshades do not worsen arthritis, except in a very small percentage of people. So the typical is, if I have a patient and they have an inflammatory arthritis and they're having so much pain and they're eating a lot of nightshades, we will do an elimination trial for 3 weeks. We'll take them out of the diet. If it helps, great, we'll stay off. If it doesn't help, we'll just add them back in 3 weeks. The majority of people we end up adding back because they don't notice a difference. In this, so I know you all don't usually look at x-rays. A pathology professor said to our lecture hall, you always look where the arrows go, right? So on this one here, this normal joint space, you can see there's a nice amount of space right in here between these arrows. This is normal. The bone is not right on top of each other. On the right side here, where we can see this loss of joint space. So this is bone-on-bone arthritis, osteoarthritis or osteoarthrosis. So this is what's so cool when we look at x-rays. When we're looking at an x-ray, we can't tell for sure how much pain that person has, because one piece is what it shows in this picture, and the other piece is how much inflammation is circulating in that person's body. There are people with normal joints that look like this one on the left that look normal or just mild arthritis that have really severe pain. And there are people with a joint that looks like this on the right side without much pain or any pain at all. So just because we have a bad looking joint doesn't mean someone has to live with pain for their life. And to go over treatments quickly. So again, I tailored this to be really the questions we get in the exam room, right? So treatments, supplements, the ones that work, the ones that don't. Turmeric. Turmeric works really quite well for some people. So it's anti-inflammatory. So just like we talked about on the food pyramid, turmeric is actually a food. It's a root. If we want to make sure that we're getting the true turmeric or turmeric, potato chop, if we want to make sure we're getting the exact thing that we want, the turmeric root, we can eat the root itself, put it in stir fries, put it in different recipes, or you can add it in as a spice. We don't know how much is enough because, again, it's a food supplement and it hasn't been tried in studies, but it's definitely something we can try if that's, and you can see if it helps. If it helps, keep taking it. If it doesn't seem to help, then save your money. You don't have to keep taking it, although overall it is an anti-inflammatory healthy food. Glucosamine chondroitin. So this, anecdotally, some people say that it really does help. Studies do not show that there's any benefit. There's no significant benefit in studies, but again, anecdotally, some people say it helps. So can it hurt? Well, any supplement down nowadays can hurt because we don't know exactly what's in that capsule or tablet. Unfortunately, study has shown. But overall, it seems like it's probably safe. If it seems to help for you, go ahead and take it if you want to. The Tylenol is now the first line treatment for joint pain. So a lot of people say it doesn't help, and so we fall back to what has been the first line treatment for a very long time, which is the non-steroidal anti-inflammatory agents. So what's interesting, if you think about it, this is when we're talking about treatment for it, these are anti-inflammatory treatments, right? So the non-steroidal, like the ibuprofen, Advil, Aleve, naproxen, all of these are anti-inflammatory medications. So they come in pill form. There's a newer one, well, it's not new, but it's new to the American market. It's called Voltaren gel. It's diclofenac, so it's an anti-inflammatory medication in gel form. So the neat thing is you can put it right on the joint where you're having pain. And then of course, if we need to, then we can do joint replacement. I put on here hip and knee because they're very different as far as the recovery. Hip replacement, people usually say, wow, this is great. I should have done this a long time ago. Knee replacement, it's a really big process. It's many months of really good hardcore physical therapy for people to get back to their functional level. The verdict is out as far as how long that's going to be. I mean, of course, they will always be around as long as arthritis is around, but more and more studies are coming out saying, hey, actually going through the joint replacement, people actually do better with less invasive treatments because at the end of the day, we still need to reduce the inflammation we're seeing for the person to have less pain. So this is the bulk of the presentation, osteoporosis. So we'll jump right in. So osteoporosis, one of the reasons we have such a hard time treating it is because it truly is a pediatric disease with geriatric consequences. The longer that, and when someone has it, and it's caused by a lot of our habits when we were younger people don't think too much about joint health, right? It's once we get in over 65 age range or over 50 age range that we're really starting to think about, hey, are my bones thin? What do I need to do about it? 1 in 3 females and 1 out of every 5 males will have a fracture due to osteoporosis. It actually is projected now that it's going to be 1 in every 2 of us that is either at risk or will have a fracture over the age of 50 here in the United States. The year was 2020 on that prediction, so we're already there. And over 1 in 4 people will die within 1 year of a hip fracture. So this is a big deal, right? As far as morbidity and mortality, it really takes a toll on society. The other piece is fractures cost more hospital days than heart attacks or strokes. So the length of time it takes for someone in the hospital and with acute care is longer as well. So what is osteoporosis? So when we're looking at this, the bone here on the left-hand side, this is what healthy bone matrix looks like in pictorial view. When we're talking about osteoporosis, we're talking about the thinning of the bones. So again, it is painless. We don't know if we have it or not. So osteoporosis is the thinning here. And then there's osteopenia, which is in between. The definition of it, in the past, we used to define it if someone actually came in and they had what we call a fragility fracture. So if they fell and fractured a bone, by doing some kind of activity that really shouldn't cause a bone fracture, falling from standing position, that type of thing. So before we had the bone density scanner, the DEXA machine, that's how we diagnosed osteoporosis. Now with the DEXA, we start scanning for females at 65 years old, or if any females postmenopausal with a risk factor, then we start screening earlier with the DEXA. There is no recommendation in the medical literature specific for males, but really it goes by risk factors is the main thing. And I know there's work to talk about, well, when do we just screen asymptomatic males without risk factors, but we don't have a recommendation yet. When we look at the results of a bone density scan, your doctor would probably talk to you about a T-score. So the T-score, what that is comparing the density of your bones to the density of the bones of a female at 30 years old. So, or the standard bone density at 30 years old, excuse me. So what we know is from 30 until as we age, it's going to get thinner and thinner, right? So anything above -1.0 or higher, that's normal bone density. If someone has a bone density of -1.0 to -2.5, that's osteopenia. If it's less than -2.5 or lower, that's osteoporosis. So that's going to be 25% bone loss from what we would expect. The Z-score, it's important to mention it. We measure that as well, and we use that score if there are secondary causes of osteoporosis, hyperparathyroidism, some other things that are not the typical, and we especially use this if we're working up a younger person for osteoporosis. I put the Frac score on here. I think it'd be interesting for everyone to know if you have interest in calculating your own Frac score. It's a tool that we use. So when someone has a bone density scan and we get this T-score back, what do we do with it, right? It's one tool that we use, but we need to look at other risk factors that that person has. If you search online, you can search for Fracs score, and it will ask you to put in your age and your weight and your height and a bunch of other information, and it will give you the risk that you will have over the next 10 years of a hip fracture or a total fracture. And if your risk for a total fracture over the next 10 years is over 20%, it is recommended to discuss with your doctor about a stronger medication or treatment for osteoporosis. So let's go over the causes of osteoporosis. So age is the biggest one. Previous fracture, of course, any steroid therapy. So we see this most often if someone has asthma or COPD, or if there are some other autoimmune diseases where they've been on courses of steroids over and over. If a parent has had a hip fracture, if there's low body weight, so the definition of that is less than 127 pounds. If there's a history, if there's current cigarette smoking or vaping, rheumatoid arthritis, and other secondary osteoporosis. So again, these are the ones that really need more conversation with their doctor in particular. If there was premature menopause, if there is inflammatory bowel disease or liver disease, or other malabsorption syndromes where we see, and I'm sorry, in here there's also gastric bypass surgery is a big one we see now because people don't absorb vitamins as normal since we changed the anatomy. Okay, so what thins our bones? So another one of my, not my favorite side, but one I use a lot. So this is what the average American is eating. So on average, Americans have 63% of our calories are coming from processed foods or food-like substance. Another 25% are coming, calories come from animal foods. And of the 12% that come from plant foods, half of that is from processed plant foods like potatoes in the form of French fries, tomatoes in the form of ketchup, that type of thing. So whole plant foods is tiny 6% of it. And this is huge as far as what thins our bones. Salt. The average American gets more than double the amount of salt that our body needs. And it has grave consequences on our bones. So it's very typical in the exam room that people say, oh, no, I don't add salt to anything. So even if we don't add salt, that's only 6% of the total salt intake for the average American. So most of it comes in before it ever gets to the table. And especially if we're having any foods that are processed or prepackaged. And I put this in here because it really surprises people typically when we talk about the number one source of salt in the American diet is bread. Bread, number one, chicken, number two. Most people don't think of chicken as having salt. If the chicken, they don't have to say that there's salt added to the chicken if they inject salt into the chicken before the chicken is killed. Then it's just part of the chicken and it doesn't have to be disclosed on the food label. So these are the biggest sources of pizza, pasta, and cold cuts. Caffeine, unfortunately, for a lot of caffeine drinkers, caffeine does thin our bones, but in full disclosure, when they did the studies, it was 5 cups of coffee a day. So it was a large amount of caffeine that they did the studies with. And alcohol, same thing. When they did studies in the past, they had looked at over 3 or more drinks a day and 2 or more drinks a day So we extrapolate that, and it's suspected that any amount than our bones, and probably a very good assumption to avoid if we don't want our bones thin from those environmental factors. So I have this in here, the inactivity epidemic that we're in. Really, I should have put someone working, because obviously the leisure in front of the TV, but a lot of times, people are hard at work during the day, but we don't work out in the fields or doing manual labor so much anymore. It's all sitting at the computer, and we're not using our bones during the day. So I was happy to get a question right off the bat about one of these proton pump inhibitors, because it's really critical we talk about. Proton pump inhibitors are a really common medication that we use for acid reflux. So Nexium's on here, but omeprazole, like Prilosec, Dexilant, there's a whole list of them. Any of them that end in the azole, A-Z-O-L-E, or a lot of them, not all of them, but those ones are in this class of proton pump inhibitors. So what those medications do, if someone has a lot of acid reflux, those meds work because it decreases the amount of acid in the stomach. But unfortunately, that affects our bones in a couple different ways, but it affects the ability to absorb vitamins, minerals, and nutrients, because we need that acid to be able to break down and get those vitamins, minerals, and nutrients out of our foods. So if someone is on a proton pump inhibitor for long term, it negatively affects our bones. Of note, when they first came out, they were meant for 8 weeks. They were not meant for long-term medications. Anti-seizure medications in our bones, and anti-estrogen or anti-androgen medications. So breast cancer treatments and prostate cancer treatments in particular look in our bones. And my apologies, I didn't put on here, but menopause, about 20% of bone loss can happen right after menopause. So how do we treat it? So again, back to lifestyle, medications and supplements, and there's actually no surgery for osteoporosis. So lifestyle, honestly, we would do the best if we can help and intervene in our younger generations before they start to have the bone loss, and really when they're building bone in that 10 to 20 year time frame. So back to the food pyramid, I want to go over a few different things in particular in more detail. So calcium, vitamin D, magnesium, potassium, zinc, these different, in vitamin C. We need all of this for good bone health. So mainly, you don't have to memorize or really hone in on everything, but just to get a good picture of the foods that are on these slides. So this one, yes, you do see some dairy. The important thing to know is what we're talking about when we want foods that have the whole package, right? We want the calcium, but we don't want the inflammation. So unfortunately, that throws dairy out the window. So all of it that comes from cow sources or other animal sources, goat, sheep, milk. But the plant-based milks are not the dairy. Plant-based milks and plant-based cheeses are on the anti-inflammatory side. They don't cause inflammation that the cow's milk causes. So calcium, we'll walk through a little more because we can see how much calcium is in each of these sources. So tofu, oftentimes when they make tofu, they'll prepare it with calcium. It's one of the binders that's used. Tofu is soybean, and they use a binder. Oftentimes, again, it's calcium to keep that together in the nice little block. So it depends on exactly the firmness of the tofu you use, how much calcium is used. But quite often, 1 cup of it can have around 700, 800, even 900 milligrams of calcium. Cow's milk and soy milk, they're the same at 300. And then if you see these others down here, you see a lot of plant-based sources. On this, I took out the inflammatory foods. So this is a list of foods that are high in calcium, but that won't damage your health in other ways. So Of note, there are a number of green leafy vegetables that you don't see on here. On here to call out specifically collard greens, kale, bok choy, and broccoli. These are green leafy vegetables that have a good amount of calcium, but it doesn't have all the oxalates that can prevent their absorption. There are some, but even with that, you get really good amount of absorption. There's a lot of information out there about, oh, you don't get the calcium from the green leafy vegetables because these oxalates get in the way. That is true for some. For instance, spinach. It's very high in calcium content, but that calcium is bound by the oxalates and the human body can't absorb it. But these ones are great sources. When we're looking at the milligrams over here too, we'll get into it more a little bit later, but the calcium intake we're looking for is around 500 to 1,000 milligrams a day, or if we're treating osteoporosis at 1,200 milligrams a day. Vitamin D. So the sun is typically how we get vitamin D. The average American is now inside a lot, and we're not in the sun like we used to be. It's actually a bit controversial right now what the normal range of vitamin D is, since that's usually set population based. But since we're not out in the sun and we want to avoid sun for skin cancer reasons, we want to get vitamin D through our diet. So mushrooms are a great source of vitamin D. It does matter if the mushroom is grown inside or outside. If the mushroom is grown outside, there's more vitamin D in it. Most people won't know that when they're buying mushrooms at the store, but just to note that it is a good source of vitamin D in the diet. I put this in here as a little plug because if anyone wants to experiment with growing your own mushrooms, there are kits that make it really fun and easy. And yes, it can be done here in Ventura County even. Okay, magnesium. Again, if you take a global picture of this in your mind, right, you see a lot of nuts and seeds, you see vegetables, you see fruits. Those are the sources of magnesium. These are the foods that have the highest amount of magnesium. Potassium, very similar, right? Fruits, vegetables, nuts, seeds. Vitamin C, same thing. Vitamin K, same thing. So I hope you get the message here. So zinc, there are some animal products that do have a good amount of zinc, but there's plant products as well that have a really good amount. So when we come back, when we're talking about whole plant foods, how do we actually keep your bones as healthy as can be? We need all of those different pieces. So if someone were to get calcium a certain way, what about all the others? The best way would be if there's one food source or different foods that can provide all of it all together, like for instance, a nice big salad. We need to mention soy because we need to nod, especially to soy, because it's really quite amazing what it can do to our bones. So there's been a lot of misunderstanding around soy. I want to call out, it has this selective estrogen receptor modulator effect. SERM is what we call it. But what's so cool is that soy, a lot of people are afraid of it, but it helps with bone health. When you eat soybeans or have any soy products, tofu, tempeh, that will bind to the bones and it will help your bones thicken and get stronger. So you don't need to worry if there's some concern about estrogen. I shouldn't say you don't need to worry. You need to talk to your doctor always. But the soy receptors that are in the bone that will be active when you have soy, those are different receptors than what's in the breast tissue or in the uterine tissue. So to put it more clearly, if you eat soy, you will activate more bone growth. You do not get activation in the breast tissue and the uterine tissue. The phytoestrogens from the soy sit on the other receptors, but effectively those receptors are then deactivated. They do not activate them. And then the receptor is no longer available for natural estrogens to attach. Exercise is the other big piece. So important enough to put it into a few different slides. So the first one is weight-bearing exercise, which really consists of pretty much all Walking is a great one because it's the one associated with the least amount of injuries. It does not include biking or swimming. Those are not weight-bearing exercises. Resistance training, of course, can be helpful. And very important to note, balance. So Tai Chi is a great way to help protect against both osteoporosis and falling, which is the second piece. One is if we have thin bones, the second is if we fall and break a bone. And flexibility. So those 4 pieces are all exercise, even though oftentimes we just talk about the weight-bearing piece of it. So to get into the meat of it here, we have a few minutes left, and supplements. So we're going to talk about supplements, and then we're going to talk about treatment options for osteoporosis. So I can't stress enough, if there's anything that you all take away from today's conversation, if it could please be that health does not come in pill form. It does not come from a supplement. So often we see that people they don't want to have pharmaceutical treatments, but then they end up taking gobs of supplements. And the truth is we do not know what's in those supplements. Again, study after study, when they've looked at supplements, even from one batch to the next batch by the same manufacturer, it's not always consistent. Sometimes there's very high levels, or sometimes there's none at all of the supplement that is supposed to be in that capsule or tablet. If we get what we need from real food, at least we know that we're getting it from a cantaloupe or from an almond. With the supplements, we don't know. The other big piece is that we're seeing a lot of vitamin overdoses because people are taking these supplements. Your body can't say no like it normally would with food. So then it's forced to absorb large amounts, and that's just very unnatural. Your body's not made to handle that. So calcium and vitamin D, of course, the most common question we get, right? So the recommendation is nowadays, if the bones are normal, do not supplement. Do not supplement. Not for bone health, at least. We do see vitamin D deficiency, and if you want, you work with your doctor if you want to supplement for other reasons, but not if the bones are normal. If there is osteoporosis, the recommendation reads calcium at 1,200 milligrams a day. That's for diet and supplement together, but to not take more than 500 milligrams of calcium at any one time. And if someone must take calcium, the calcium citrate is the better option because it's not affected as much by the amount of acid in our stomach, which can vary based on our age or different meds that we're on. Vitamin D, 1,000 international units daily. Again, that's diet and supplement together, but just caution because we can't take too much of either one of them. Possible side effects. So this is why the recommendation has really pulled back on calcium supplementation. The studies did find that there were increased number of heart attacks and strokes, and there was even a study that showed that there was increased number of fractures with people that were taking calcium supplements. When they first did the study, it was done on institutionalized women. And so it was very different than the average population of people out and about. And it's very individualized. So please talk to your doctor. Again, it has a lot to do with absorption, if you've had prior surgeries, if you have known vitamin D deficiency or gastric bypass. Okay, if people want more information, I should have warned you at the beginning, but you can take out your phone. If you take a picture of this QR code, or if you point your camera to it, it'll take you directly to the site of nutritionfacts.org. It has the 5-minute video on calcium and vitamin D. This site, it's a great site for all evidence-based nutrition. Any information that you want to get, you can type it into their search bar. Again, it's a nonprofit and it's all evidence-based nutrition facts. I'll put it up at the end if anyone's interested. So, okay, 3 different medication types. One is bisphosphonates. This is the #1, the go-to treatment if someone does need to be on pharmaceutical treatment for osteoporosis. It comes in either a pill or infusion. Serious side effects that come about. and the monoclonal antibodies, so Prolia. So this is an injection that can be done every 6 months, excuse me. We usually go to this if someone cannot tolerate a bisphosphonate or if they've been on one of those medications for over 5 years. The drawbacks are the cost. It's really pricey and some insurances don't want to cover it. To me, the biggest drawback is that it's a newer agent. We don't know all the side effects. We know what happened with the bisphosphonates, that we didn't know about those atypical femur fractures until after the fact. There is a short-term effect. So if someone is on Prolia and they've been on it 10 years and then they stop, at the time that they stop, the bones go back to the thinness that they were before they were on them. That effect does not stay. And we have no data beyond 10 years. And estrogen, I always get questions. So the risk outweighs the benefit of estrogen. So we do not use estrogen for bones. And just a reminder about how cool soy is. So overall takeaway, of course, you all see doctors running around nowadays, right? So when we're running around mopping up, let's turn around and turn off the faucet. And let's see if we can stop this before it gets worse for our younger generations. And I'll leave it at that, Jay. Thank you so much, you all.
That was absolutely wonderful. Thank you. Thank you, thank you, thank you. I was furiously taking notes. I hope all you were too. Very, very cool information. So we do have a few questions. Now, before I get into the specific questions, I would like to give Dr. Cox the opportunity to talk a little bit about medication recommendations and what she suggests. She covered it in her presentation, but just before we get into the questions, I'm sure you have a general spiel that you'd like to say.
Oh, okay. So as far as it's hard to say because it's so individualized. So some people do need medications. This would be the biggest thing I would say. Some people absolutely do need medications for osteoporosis. And for the most part, if we can all remember that lifestyle is the first treatment. Unfortunately, medication in general is quite is prescribed a lot quicker than having this conversation around the lifestyle factors that make a difference. Does that make sense?
Yes, yes. So it's just really hard for a doctor who doesn't have you in front of them and doesn't know your history to recommend medications. But I will go ahead. Some questions were answered during the presentation, but we do have a couple here. Judith asked, now this is something that you might have already covered. Voltaren developed a rash on my skin and I've been avoiding NSAIDs because of my medication for my heart. I wonder if it's safe to prescribe. Again, this is a medication question.
Yeah. So thanks for the question, Judith. So, as far as that goes, I would not recommend the Voltaren or any more of the non-steroidal anti-inflammatories. Sometimes, unfortunately, very underutilized. I didn't even put in this presentation, but ICE. It's a very potent anti-inflammatory treatment, so that could help. And the other thing to look at is Salonpas, or Salonpas has in it menthol and camphor. I recommend it to patients a lot because it's a sticky pad and you can stick it right on the joint, on the sides of the knee, on the back. If there's any heart condition, I would not use more than one Salonpa at a time before checking with your doctor.
Thank you. Wonderful, wonderful. Would you, Debbie asks, would like to know your opinion of transdermal vitamins.
So that's a good question. I do not recommend general vitamin supplementation at all. Never, except vitamin B12, if someone's on a plant-based diet. So again, the vitamin overdoses we see, it's really significant. And then of course, there's a lot of vitamin overdoses that we don't see because we don't typically check vitamin levels in the blood. Please treat vitamins just like we treat pharmaceutical medications. I love when people come in with the list of possible side effects and they're like, I'm concerned about these. You should be. You're putting that in your body. We should have that same vigilance with supplements as well.
Absolutely. Nancy asks, you did mention soy milk, but what about almond or cashew milk?
Oh yeah, that was an oversight on my part. Yeah, absolutely. Almond milk, cashew milk, soy milk, all of them are great. They're anti-inflammatory. Please make sure to look for the unsweetened version, because with all those milks, they add in sugar. So it will have about the same nutrition content that the cow's milk has. I'm sorry, not nutrition content, but about the same sugar level as the cow's milk. But we don't want that sugar. That's inflammatory.
Okay, and let me pop over the chat here. Okay, calcium recommendation if osteopenia.
That's a good question. To be honest, I left it out on purpose. And that's really not fair to you all. I left it out because it's just so controversial. So it's controversial because what's in print for recommendations is not what's best for human health. If we look at other countries' recommendations, it gives us a better look at what's truly best for human health when there's not industry writing the recommendations. So like the UK, they recommend calcium intake of 700 milligrams a day, not the 1200 we see here in the United States. So they've peeled back. They used to recommend 1200 milligrams a day of calcium for osteopenia as well. They have now retracted that. It looks like, if we're just talking health and not recommendations, it looks like what we want is 500 to 1,000 milligrams of calcium a day in diet. If we can't get enough via the diet, then to supplement. But if at all possible, the diet is the very best way.
So just to clarify, keep track of how much you're actually getting in the diet and just supplement that little piece, not the full amount. Wonderful. Sorry.
Oh, they did recommend, in the past, it was recommended 1,200 milligrams of supplemental calcium for osteoporosis. So they have greatly pulled back those recommendations, and they're really due for another pullback. Yeah.
Wonderful, wonderful. So you talked about, the age. Is there any possibility of building more bone? Like how much good are we doing by exercising, for example?
That's a good question. It's not much, to be honest. If, once we're past, it's not much, but it at least maybe it's something, and it's helpful on other levels. So if we're looking specifically at, okay, is the bone thicker? Exercise doesn't do too much as far as that goes. It cannot, right? We're losing the bone since we were 20. But what it does do is it really helps. It keeps the tendons and the ligaments as mobile as possible. It keeps the muscles stronger. It gives us more flexibility. It gives us more agility. All these other things that help with preventing falls and fractures. I'm going to put this up. I hope you all can see this, nutritionfacts.org, the
Yes.
QR code. Okay, perfect. So if anyone of you want, please just point your camera at it, and then something will pop up at the top of your phone, and that will open it directly to that website.
Okay, we have another question here about a specific exercise. So somebody's asking, Teresa, thank you, Teresa, is asking about, the benefits of bone growth using a rebounder.
Mm-hmm. That's a good question. I don't know the answer. I'll have to find out.
Just make sure that you are on our email list. You can sign up for that. I will give you some details about our resources in a moment on prevdoc.com, and we'll be sending out more information. And if anybody has any additional questions, you can reach out to us there. And I'm also going to be providing for you Dr. Megan's free resources and my free resources and the free resources that we have together. And so a lot of really good stuff out there. And if you do have questions, one of the best ways is to have a nice chat with Dr. Megan Mitchell Cox when you go and do her walk with the doc the first Saturday of every month. So this is a perfect opportunity to walk and chat. Plus you're doing good stuff for your bone health, getting some sunshine and some weight-bearing exercise. I am going to go ahead and put those details in the chat right now. If you have any last questions, please feel free to pop them in really quickly. We're just about done here.
Okay, and you know, since we have another minute, I'll say, just thinking out loud about the rebounder question, what we're really going for with the weight bearing exercise is we want that impact, right? When you're walking and your foot hits the ground, that equal and opposite force, right? Your foot hits the ground and then that sends a force back up to your bone, and that's what causes, or that's what is helpful. So the rebounder does do that. It's probably not as good as jumping up and down on the regular floor as far as bone health goes. Of course, gentle on the joints. But so I say that because I don't know if I'll be able to get a really good scientific answer about the rebounder in particular. Theoretically, it makes sense that it might be more helpful, but not as helpful as jumping up and down on the regular floor.
It's all about the PSI, right? The pounds per square inch pressure on the joints. So the rebounder is a little bit gentler, but you know, that's a benefit in some, so it's all about that risk benefit analysis of that, right? I am just going to go through quickly. I just put it in the chat, but I want to go through quickly what we have here because it's a lot. And some people might just see that's a lot of words and not want to read it. So, so what we have here is Dr. Megan Mitchell Cox, her website. She has a lot of great information on there. So please do check that out, meganmescher-cox.com. And on that is the Walk with the Doc information. And you'll see all the topics that she has set to talk about, and really good stuff. Go ahead and check that out. And then the prevdoc.com, which is the disease prevention and reversal. And so you'll see the future webinars that we have coming up. I will be doing the next one, and it'll be about eating for brain health. And so I'm very excited about that one. It's one of my favorite topics. My favorite organ of the body is this one right up here. So you got to protect it. And there are lots of things that you can do.